So basically, when I was trying to come up with a lecture topic, I wanted something that would captivate the audience. I didn't know I was going to be competing with insulin, though, so that's going to be really tough, and I got an hour time block. I'm going to try to keep you all awake. Doing interventional work, I would say my heart and passion is more so invested in pancreatobiliary disease, but what I'm going to talk about today is a far more common issue and is probably the most common reason I get consulted in a hospital-based practice. So GI bleeding is only going to become more prevalent, I suspect. Dr. Ahmed's medications, the NOACs, DOACs, antithrombotics, becoming increasingly more utilized. We just seem to be running into a lot of GI bleeding, and I think it's an important topic to discuss. So I have no disclaimers, no conflicts of interest. I skipped an objective slide. My objectives are simply to inform, update, and hopefully educate with regards to some of the contemporary changes with regards to GI bleeding management strategies, and maybe some things that aren't performed optimally in the hospital setting that I run into commonly. So this is an Alabama salad bar, if you've never seen one of these, also known as a Big Mac. And I'm not trying to tempt anybody or anything like that. The reason I have this here is because this is the way that I structure my lectures. So I like to start with a clinical case and then get down into the meat, which is contemporary information, guidelines, things like that, go back to the clinical case, get back into some guidelines and management strategies, and end with a clinical case and just talk about the resolution thereof. So we will start with said case. This was a 72-year-old woman that presented with a 5-day history of melena to our hospital. She was a little tachycardic, marginal blood pressure, but overall pretty stable. Came in with a mild degree of anemia. She was slightly supratherapeutic on her warfarin. Didn't have any abdominal pain on presentation. She was taking way too much aspirin for shoulder pain and also had been taking her warfarin as prescribed for AFib. So 3 hours after she came into the ER, she developed melena, which again was kind of her chief complaint that she presented with, which evolved into hematochezia. And I think that always deserves a great deal of attention when you see that transformation from melena to hematochezia. Pay very close attention to that. Her follow-up hemoglobin was down almost 3 grams. So she was given 2 units of packed red cells. She was started on Protonix, and rightfully so. The gastroenterologist that was the GI nocturnist saw her and put her on oral Protonix. She was admitted to the ICU, so I think appropriately dispositioned. So we were consulted, and again, the nocturnal GI saw her, and I ended up seeing her the following day, but she was scheduled for an EGD in the morning. So gastrointestinal bleeding, like good real estate, it's all about location. Upper GI bleeds are the most common location for gastrointestinal bleeding, comprising about 40% of bleeds. The lower GI tract is responsible for about 1/4 of them, and somewhat frustrating, we get into the obscure overt bag, which obscure means you don't know where it's coming from, and that's after endoscopy, and that's an upper and a lower endoscopy. Overt means you see it, so there's melena, hematemesis, hematochezia, but you can't clearly define a source. And frustratingly so, that's 35%. So with regards to upper GI bleeds, there's about a 5% mortality across the board. Generally, mortality is related to underlying comorbid medical ailments, so multi-organ failure, pulmonary conditions, malignancy, things of that nature. Exsanguination is exceedingly rare in our current medical climate in our country. I can think of one person I've actually seen bleed to death in 5 or 6 years. That was a varicose bleed, and that lady was ill to the point where it was more of a withdrawal of care situation. She wasn't headed down a good path. There wasn't going to be a whole lot to get back. So exsanguination is not very common. I think that statistic is probably grossly overestimated in my experience. 44% of these, occur in people over the age of 60. So as far as upper GI bleeds, the UCLA cure data is where most of our data was procured for peptic ulcer disease. That database was started well over 10 years ago. So the table that you see there is from the UCLA cure database. Peptic ulcer disease is by far and away the most common etiology of upper GI bleeds, followed pretty distantly by gastric and esophageal variceal hemorrhage, and then you see a scattered variety of other types of bleeds. The duodenum is the most common site for ulceration. Luckily, most of these resolve on their own after proton pump inhibitor therapy is initiated in the emergency room in the hospital setting. And generally, by the time I'm down there doing endoscopy, most of these I don't have to do a great deal of work on. In the absence of cessation, though, people that have ongoing bleeding, the mortality is high. It's 25%. Independent risk factors for bleeding are people that are older, age 65 and greater. Again, that's probably more so related to comorbid medical ailments. Use of NSAIDs, don't forget about aspirin, 81 milligrams, which so many people are on, and a history of peptic ulcer disease in the past. So for risk stratification, and one of the points I really want to drive home today, I'm going to talk about risk stratification for upper GI bleeds and lower GI bleeds. There is data that suggests that using a well-validated scoring system to risk stratify these patients is probably better for our patients than just a blanket guess as far as where patients should be dispositioned. How do you care for them? So for upper GI bleeds, the best validated system is the Glasgow-Blatchford system, and that's what I've got pictured here. I don't know how many people in this room actually have a smartphone, probably everyone, but there's a wonderful app called MD Calc, and MD Calc has almost every scoring system you can imagine, and the GBS scoring system is included there. What I really want you to take from this today is people that score over a 12 on this system. Those are very high-risk patients in terms of mortality, rebleeding risk, and this is important for disposition. If you're a hospitalist, if you ever work in an emergency room, very, very important, or the outpatient setting. So if you have a GBS score of 0 to 1, there's less than 1% chance of requiring any sort of intervention. So those people are appropriate for outpatient disposition, even if they come into the emergency room. So those would be folks with a BUN less than 18, hemoglobin greater than 13 for men, 12 for women, systolic blood pressure more than 110, not tachycardic, no melena, no syncope, no congestive heart failure, and no advanced liver disease, cirrhotics, alcoholic hepatitis of the acute variety, things like that. I will tell you, I believe that guidelines are guidelines. They're not gospel. So recently I had a lady that presented, and she had a GBS score of 2. She'd been sitting in the emergency room, and like most ERs right now, everybody's understaffed. We were waiting on hospital beds. She was from a nursing home, been in our ER for about 36 hours, had coffee ground emesis. She had a hemoglobin of 13, feeling great, seemed to have a little viral bug, but the nursing home said that they saw hematemesis that was dark. I hear that so often, I'm almost tone deaf to it nowadays. But when I calculated her GBS score, because she was in her 80s, she had a creatinine of about 1.4, her BUN, you can imagine, I think it was around 20 to 22. So she was a 2 on the GBS score. I sent her back to the nursing home. I talked with her family, and I said, hey, I believe that this is probably nothing to worry about. Put her on a PPI, gave her my office number, and I said, by all means, if you guys see anything to be concerned about next week or so, call me and I'll fit her in for an urgent outpatient endoscopy. And I think that's always appropriate. But if you have to disposition these patients, that's a very important piece of information. Also, from a litigation standpoint, you have a validated scoring system saying that you did your job. So the presentation of upper GI bleeds, hematemesis comprises about 30%, melena 20%, and patients present with both in about 50% of cases. Don't forget that hematemesis can be of different varieties, so that can be dark black, maroon, bright red. Hematochezia in an upper GI bleed, as I alluded to earlier with the case presentation, that's almost always bad news. So that's got about a 15% prevalence in the UCLA Cure database. It's almost always accompanied by hypotension, oftentimes altered mentation, and a severe degree of anemia. But don't forget, when people are bleeding acutely, they will equilibrate, and they will take time to equilibrate with their hemoglobin. So you may admit somebody to the ER that has a hemoglobin of 10 or so, and you're not very concerned, but that's soon to change in this scenario. I am not a huge fan of hemoccult testing in the hospital setting. In the outpatient setting, I do think it's got its time and its place, but I think if you see evidence of overt bleeding and somebody's anemic, hemoccult testing is a very minimal benefit. I oftentimes use hemoccult tests, whether it be fecal occult blood test or a FIT test, to talk me out of doing endoscopy, and more so to arm myself with information to talk to the patient about really bad sedation candidates, really bad candidates for procedural intervention, high risk but low risk of having significant pathology, or even if they do have significant pathology, perhaps their state of health is not good enough that you're ever going to be able to change an eventuality or outcome. Hemoccult testing is one more bullet in your gun to say maybe we shouldn't be doing this test. So the management of these patients, within the first 5 minutes, I think the first thing you do anytime you see a patient, you're looking at the acuity. Are they sick? Are they well? And a severity evaluation is paramount. So if the patient's unstable, yes, you still want a history, you still want a physical exam, but if your patient is crashing, then a history and physical exam is of minimal value, and you should move on to resuscitation. But with regards to the history, the things that I like to key in on, abdominal pain, did the patient have any pain with the bleeding? And I try to differentiate pain from cramping, because blood is a cathartic. It's like a laxative in the GI tract. So almost everybody that bleeds is going to have some degree of cramping, but I would describe overt pain very differently. So when people complain of pain, I start thinking about malignancy. I think of peptic ulcer disease. I think of ischemic bowel. Those are the things that I typically run through my brain when I hear that. Duration of bleeding, is it acute? Is it subacute? Does it have some intermittent chronicity to it? NSAID use is always important. I document that in 1 out of 1 consults that I do. Antiplatelet medications, anticoagulants. I think those are very important because they tell you how you're going to have to manage these patients to some degree. I don't know that it changes management necessarily, and I'll get a little deeper in that in just a little bit. But it's an important piece of the history. They don't often cause bleeds, but they will often make bleeds a little bit worse and more severe. Something that is glossed over really frequently, you don't want to see one of these. If you have seen it, you know that they're bad. But with vascular graft patients, people that have had a AAA repair or something like that, when somebody comes in complaining of melena, they have one large bleed, and it's a large melanotic bowel movement, a large maroon bowel movement. They have a little bit of cramping, and they feel better, and they've had a graft. I would encourage you to contact a vascular surgeon and make sure you're not dealing with an aortoenteric fistula, because you have one opportunity usually to diagnose that, and the time is never endoscopy to diagnose that. It's during CT scan. Oftentimes, if you make it to endoscopy, those patients don't live very long thereafter. Risk factors for cirrhosis. You must delineate whether or not these patients are cirrhotic to the best of your capacity, because they're managed very, very differently. So, of course, we're talking about variceal bleeds. Variceal bleeds, the time frame is significantly different from the average upper GI bleed. So I talk to patients about alcohol use. I look at their platelet count. That's generally the first biomarker and giveaway that somebody has cirrhosis, is thrombocytopenia. And oftentimes you'll find out that these patients had occult cirrhosis for many years, because you'll see a chart history of thrombocytopenia for 5 or 6 years, and it's just been glossed over. IV drug use, risk factors for viral hepatitis otherwise that I wrote down there. Don't forget about the baby boomers. They were significantly higher risk for exposure through the medical system, and IV drug use as well. A brief physical exam. This can be pretty fast and cursory if it has to be. Are they sick? Are they well? Are they cold? Are they warm? Abdominal pain. I check the oropharynx. I look for black. I look for red. A rectal examination is so frequently glossed over. Nobody likes doing rectal exams. Nobody likes having rectal exams done, but there's a lot of value in an index finger. And another thing that I do in patients that are pretty sick, especially the ones that are bordering on instability or are unstable, I always lift the gown up and I look in between the patient's legs. It's shocking to me how often you'll learn everything you need to know just by looking underneath the gown. There's pooled blood that's maroon, that's red. And you know, if somebody's bordering on instability, they've got a major problem going on when you see that. So management, resuscitation. Again, resuscitation is the first step in any GI bleed. You don't want to initiate this too late, because the consequences can be catastrophic for obvious reasons. If you have suspicion for a massive upper GI bleed, I recommend intubating the patient. Over the past year to 2 years, ASGE and some of the other GI publications have put a lot of research studies out about this, and the data is not really clear-cut. There is some data that suggests that maybe prophylactic intubation, oftentimes we jump the gun, and maybe it's deleterious to the patient. My personal feeling anecdotally is I have seen this save a lot more lives than I've seen people at harm. So if people have ongoing hematemesis, if they can fill up a coffee cup of bright red blood, you better consider intubation from my standpoint. If they become altered, they're starting to get obtunded, that's an indicator, or altered respiratory status. The main reason, 22% chance of respiratory complications, and of those 22%, 70% of those folks die. If the patient isn't hypotensive, I like orthostatic vital signs. Oftentimes, orthostatic hypotension precedes actual resting hypotension. And then, of course, verify that the patient is dispositioned appropriately. I would say in the hospital setting, I oftentimes see people disposition to the ICU a little bit too frequently, but it's probably better to disposition somebody to the ICU as long as you have available beds than wish you had when somebody's on the floor, nursing shortages and things like that. Some of these floor nurses are covering 6 to 8 patients. And if these people start to decompensate, they may not be able to talk to their nurse, they may not have family at the bedside, and they get into trouble in the middle of the night. The transfusion we'll talk about here in a little bit. There's a lot of data coming out about that. There's been a lot of data about that over the past 20 years, but I think we have really good firm data on what we should do with blood transfusion with GI bleeds and otherwise. I like to keep the platelets above 50,000. INR less than 2 is okay. We'll also talk a little bit more about that with regards to reversal agents with some of the oral anticoagulants and things. Restrictive transfusion. It's very important, but I would say be careful applying that to people with hypotension and cardiovascular disease, and I would overwhelmingly encourage you to not do that. If somebody's hypotensive, I would go ahead and transfuse, and if you happen to over-transfuse them, so be it. You're probably going to help more people than you harm. If the patient has a confounding source, you can always consider placing a nasogastric tube. My big caveat to that is please make sure that the patient is not cirrhotic and has no evidence of cirrhosis, because it makes me cringe when I get that phone call, hey doc, we put in an NG tube and there's bright red blood down there. And then I look at the platelet count and I see that it's been 30,000 for 4 years, and I know that we've got a variceal bleed, oftentimes provoked by a nasogastric tube. You knock off blood clots, you hit an ectatic vessel, and they just let loose, and they're big trouble. Very high mortality. So this came from the ACG website. This is from the 2021, which is the most recent set of guidelines we have for management of upper GI bleeds. So basically, this is the crux of the recommendation to employ a restrictive transfusion strategy with upper GI bleeds. So you can see the study here by Villanueva. The liberal transfusion benchmark was 9 in that study, and by Gyrath it was 10. But you can clearly see here, further bleeding was exacerbated in the liberal arms of both of these studies by a significant percent, and the mortality went up. So that's why we employ the restrictive transfusion strategy, and I think this goes along with data that has been dogma for several years now. Medical therapy. So we know that in the human body, there isn't much that functions well in an environment of extreme acidity. An acidic environment impairs clotting factors, impairs platelet aggregation, and really not that much different than what happens with catecholamines in the serum when somebody's in shock. So I always like a proton pump inhibitor on board with these patients. I don't think there's any role, and really data supports no role for the H2 blockers like Pepcid, Zantac, those medications. Obviously, people are trying to avoid PPI therapy in a lot of patients because that's a whole nother topic right now, but in the acute setting, PPI therapy is absolutely warranted. This next statement, in the old guidelines from 2014 or 2015, when they were revised in 2021, we used to think that pre-endoscopic therapy with a PPI reduced the need for intervention at the time of endoscopy. Well, new data says that maybe that's not true. I would argue with that anecdotally, and I am very much in favor of employing early PPI. I think it oftentimes does get us out of an awful lot of trouble. There's also a timing component to that, which we'll get into in just a second. IV infusion versus intermittent dosing, like 40 IV BID, 40 PO BID, those things. There's not great data out there. We do know that in the setting of an upper GI bleed, a high-dose PPI regimen is recommended, which is at least 80 milligrams per 24-hour time period. However you choose to administer that, 80 milligrams is that mark where we say that's a high-dose PPI regimen. And I think it's always a good idea when somebody presents to the hospital with that. This is all retrospective, the way that our data works, so we kind of base the recommendation with PPI therapy on endoscopic stigmata. So empirically, if the patient requires admission to the intensive care unit, I'm a big fan of a pantoprazole drip. I do think that there is something to that drip, lowering that basal pH and keeping the acid suppressed. I do find that patients tend to do a little bit better with that than intermittent dosing. That's my personal opinion. I don't know that data is as supportive. It's not deleterious, we do know that, so it's not going to hurt anything. It is more expensive, that's the downside. If the patient has a high degree of likelihood of cirrhosis, probably the most common mistake with these patients isn't the lack or the presence of institution of octreotide or sandostatin. Most ER docs get that one right. Most hospital docs get that one right. And these patients are very high risk for bleeding to death. You know, it's got a 60% mortality when somebody comes in with a variceal hemorrhage. But the most common reason that cirrhotics die is infectious complications. And what people oftentimes forget about is every cirrhotic that bleeds needs to be on a third-generation cephalosporin. So I give Rocephin 1 gram IV Q24 hours. I think that's extremely important and oftentimes forgotten about. Can I take your question at the end? I'll be happy to answer that in detail to the best of my capacity. So I want to get back into our clinical case. So we're in the middle of the Big Mac right now. So the patient had ongoing hematochezia overnight, bloody bowel movements very frequently, every 15 to 30 minutes. So they were given 2 more units of factor of blood cells, now with a total of 4, 2 units of FFP, and the AM hemoglobin didn't change from when the patient was previously transfused, so stable at 7.7, not in good shape. So there was a GI transition of care. That's when I saw the patient, took the patient from the nocturnal gastroenterologist, and I saw them pre-endoscopy for the very first time. They had a definitive mental status change relative to what was previously documented, became lethargic, they were a little obtunded, tachycardic, but still with a good blood pressure. And I lifted the gown, and there was that maroon blood pooled between the legs. The SVR was still low. The patient was still warm. She had not, to this point, had any nausea or vomiting, so we decided to move on with the EGD for treatment of presumed brisk active upper GI bleed. I called the blood bank, got 2 units of blood on order, 2 units of plasma, and 2 units of platelets. I'll tell you why I do that, too. The patient was taken to the endo suite. Right there before my eyes, she had a sudden change in her mentation. She became hypotensive. She started retching, and a very large blood clot came out of her mouth, and we were frantically trying to evacuate it so she didn't aspirate. Skin instantaneously became cold and clammy, and she was very, very sick. So we postponed the procedure in favor of resuscitation, which I would almost always encourage y'all to do. We called a rapid response. I got some help from my anesthesia colleagues because she was in bad shape and decompensating right before our eyes. We put her in a larger room, gave her 2 liters of fluid, gave her some neosynephrine, her blood pressure improved. We sent for the blood products that we previously ordered, and I talked with the family and said, hey, your family member is decompensating. I think they need to be intubated so that we don't put her at risk for aspiration and cause another problem in addition to the bleed. So moving on, after she was intubated, this is the endoscopy picture that I was able to get. So basically, the image on the left, this is in retroflexion, so in the stomach, looking back up at the scope coming out of the esophagus, and that's blood pooled in the gastric cardia. It's very fresh. And the image on your right is the source of bleeding. It's that little protruding area with blood adherent to it in the 9 o'clock position relative to the pylorus. So back down to a little bit more of the meat. So the image that you see down there on the right, that is the Forrest classification for peptic ulcers. It's how we classify all peptic ulcers. It's basically the way that we risk stratify these things, and I've kind of described each one of those there on the left. The most important thing here with regards to upper GI bleeding, we used to do a really, really bad job at this, and even when I was in fellowship, so that was 6 to 9 years ago that I was in fellowship, and we would rush into the hospital, go to the ICU when these patients were admitted, and we would scope them immediately. And I vividly remember people decompensating and not doing well, especially when they got propofol and got some of the other medications that are known to drop blood pressure. So we now know that these patients, they need to be taken care of, but within 24 hours is the optimal time frame. It doesn't need to be within 2 hours. It doesn't need to be within 6 hours. Within 24 hours. And I can speak to the frustration of hearing that sometimes as a hospitalist, because I was one at one point, and I remember my GI doc saying, we'll get to him tomorrow, we'll get to him tomorrow. Well, now I say that, but I say it with good reason. I try to educate when I say that. It's not because I don't think the patient's sick, it's because we were causing harm when we rushed to endoscopy. So stability, it always reigns supreme. And I won't go through every one of these ulcer types. There's really not a great deal of reason to do it, only to know that active arterial bleeding, the Forrest 1As, the oozing hemorrhage, the non-bleeding visible vessels, and the non-bleeding adherent clot, those are your high-risk stigmata. We employ endoscopically usually 2 modalities of hemostasis instead of 1 because the patients have a lower risk of recurrent bleeding. Variceal hemorrhage, again, different animal. So the standard with variceal bleeds, and the reason to really delineate that early, if you can, to the best of your capacity, it's not always possible, and I think we all understand that. Sometimes people are not thrombocytopenic. They don't have splenomegaly. They're not drinkers, and you don't expect to be walking into a variceal bleed, and lo and behold, when you put a scope down, you realize that's what's gone on. But if you can, try to identify those folks. They need to be scoped within 12 hours, and that's about the only type of bleed that will get me up in the middle of the night out of a cold, dead sleep. I do go in for those routinely, pretty rapidly. Resuscitation still reigns supreme, but there exists a scenario with a variceal bleed where these people bleed so vigorously, if you don't put a scope in them, they will die. So sometimes stability be darned, you have to go in and you have to try to take care of the patient. We typically use band ligation. It's really simple. It's really archaic. We actually suction the varix up into an accessory cap that's put on a standard endoscope tip and ligate the varix with a rubber band. And it basically sloughs off within about 72 hours and forms an ulcer. Saves a lot of lives, but it's an archaic device. We've used it for a long, long time. Again, the SBP prophylaxis, I continue that for 5 to 7 days. Usually these patients, if they do well after band ligation, hospitalization, as long as they're stable, doing well, no evidence of rebleeding, 72 hours is a long enough hospitalization for these folks. So I'll keep them on an octreotide drip for 72 hours. I will initiate the SBP prophylaxis with Rocephin, and when they can start tolerating oral intake, or if they're extubated, then I switch over to Omnicef 300 BID and continue that for about 3 or 4 days after they are discharged. So again, this is a study by Kumar that was done in GIE back in 2017, and these people were brought for urgent endoscopy, which in this study was defined as less than 12 hours. And this was one of our first studies that demonstrated perhaps this is not a great idea. So there were 361 patients in this. The primary outcome, death, rebleeding, need for operative or interventional radiology intervention, or endoscopic reintervention. The GBS score was calculated at presentation. Again, 12 was at cutoff. 12 is the high risk. Less than 12 is lower risk. 10% of the patients experienced the primary outcome, which is not insignificant. The important thing to know is what this did was urgent endoscopy resulted in a 5-time increased risk of reaching that primary outcome. So it was extremely harmful. And in this study, the needle wasn't really changed for the high-risk folks. The high-risk folks, they basically did the same. But the lower-risk patients, the people that should not have gotten as sick, they should not have died, well, they did. So they died, and they got sicker, and they rebled, and not so pleasant things happened to a patient population that was lower risk. So you know that something's grossly inappropriate. So fast forward, this is 2021. when the ACG compiled their new guidelines, and this is the study that they cited as their reason for recommending a less than 24-hour time period for endoscopy as opposed to urgent. Urgent in this one was less than 6 hours. Again, GBS score cutoff was greater than 12, so basically you can see these people bled more, they died more, and they required repeat endoscopic therapy more often. So same exact outcome, with the exception of this did affect those higher risk patients, because these are all GBS patients greater than 12. So not only do we have a study that says you're moving the needle in the wrong direction on the low risk patients, but now also the high risk patients too. Post-endoscopy, so again, these high-risk stigmata, arterial bleeding, non-bleeding visible vessel, non-bleeding adherent clot. I do a high-dose PPI for 72 hours. That is also straight out of the guidelines. When you look at how PPIs are administered, the data is a little bit confounding, because when you go back to the 1990s and the early 2000s, a lot of these studies were in Asian populations. Well, as you know, in Asian populations, there's a high rate of H. pylori endemicity. So when you've got that, people's basal pH is actually higher with H. pylori. So we kind of wondered, perhaps the reason we didn't see as robust a difference in a PPI drip versus intermittent dosing, was it because these people have a better response to a lower dose of PPI therapy? And I don't have a clear-cut answer, but again, I will tell you that I use a lot of PPI drips, and I still adhere to that. I will keep these patients on a clear liquid diet when they've had high-risk stigmata for 24 hours, basically so at the drop of a hat, if they rebleed, I can go back and I can repeat endoscopy, and I don't have to worry about aspiration, I don't have to worry about food being in the way, and we don't have to have a 6-hour delay for that patient to go through a phase of gastric emptying. I also continue the PPI BID, usually 40 milligrams of whichever PPI you choose other than Dexilant. The dosing's different on that. 6 to 8 weeks post-discharge should be fine. Oozing bleeding, the data is a little bit controversial. We don't know which way to go on these patients. Do you treat them as though they have high-risk stigmata, or do you treat them like they're a little lower risk? I treat them just like the high-risk stigmata, and that's just based on my own personal experience. A clean-based ulcer, that would be like a Forest 3 ulcer, and just to go back to show you what that looks like, if your GI doc ever includes photographs, that's at the very bottom of that image on the right side. Clean-based, no hyperpigmentation or anything like that. Those patients can be treated and they can go home, and you can do daily PPI therapy after that. Non-peptic ulcer disease, lesions of the upper GI tract, they're really, really poor recommendations. We don't have robust data sets. So the recommendations as far as guidelines, I would say they're not as clear-cut. Variceal hemorrhage, same deal. I keep them on a soft diet for a total duration, typically of 72 hours, just to prevent band dislodgement. So I usually say stay away from chicken, pork, steak, big pieces of bread, and don't eat anything thicker than, say, chewed up macaroni and cheese, just to prevent having those bands slough off, because they will bleed immediately. Recurrent bleeding, I'm going to go into this in a little bit after we talk about lower GI bleeds, so I'm not going to spend a whole lot of time on this slide. Just know that some predictors of recurrence, active bleeding at the time of endoscopy, as we talked about, that is a very high, that's a 25% mortality if those people are actively bleeding, still despite adequate PPI therapy. Ulcers bigger than 1 to 2 centimeters. Posterior duodenal bulb ulcers are bad news because they get into the circulation of the gastroduodenal artery and tend to bleed heavily. And for the same reason, circulation issues, the lesser curvature of the stomach, those can be problematic. So to move on a little bit, lower GI bleeding, also known as severe hematochezia, is predominantly caused by diverticular bleeding. By far and away, that's the most common reason you're going to see somebody coming in with voluminous bright red bleeding per rectum, followed distantly by internal hemorrhoids. They will see a lot of blood or perceive that there's a lot of blood with internal hemorrhoids, but it's not going to be voluminous. Typically, those patients are not going to drop their hemoglobin appreciably. The thing to be aware of with a presumed lower GI bleed is 15 to 20% of these patients that come in with this severe hematochezia actually have an upper GI source. And those are bad news. That's usually a very large, rapidly bleeding duodenal or gastric ulcer, or could even be a variceal bleed. So be aware of that, especially if somebody develops hemodynamic instability. it is extremely uncommon that a colonic bleed results in hemodynamic instability. Spontaneous cessation is generally the rule in these. Most often, by the time we get the patients cleaned out, get them prepped, and we do a colonoscopy, usually they've stopped bleeding. They have a lower mortality rate, as we discussed previously, than an upper GI bleed. So risk stratification for these patients, upper GI bleeds, we have the GBS scoring system. For this one, the most well-validated and the most utilized currently is the Oakland system, and I'll show you what that looks like, but you won't be able to see it unless you brought your telescope with you. But I'll just tell you, go to MD Calc, type in Oakland, and you can risk stratify these patients. So independent predictors of severe lower GI bleeding and bad outcomes: abnormal vitals 1 hour after they come into the emergency room and get their initial assessment; gross blood on digital rectal exam, which is, again, underperformed in my opinion; hematocrit less than 35, or if they've got significant medical comorbidity, which in this scenario, most often we're dealing with older patients. They almost always do have a lot of medical comorbid illnesses. So again, there's that Oakland score. I know you can't see that. I could not find a way to make that better. I just want you to know that's what you put into your smart device. Put it in when you've got a lower GI bleed, and it will give you the information that you need. Once again, very important for disposition, because if you score less than 8, or your patient scores less than 8, they're safe for discharge, and these patients can be followed up as outpatients. They don't need to be hospitalized. I think with our crowded emergency rooms, crowded hospitals, hospitalists are extremely busy. This is very important. Try to disposition these patients appropriately to not waste time and money. So in the first 5 minutes with lower GI bleeding, it's not any different than an upper GI bleed. With the severity evaluation, if they're unstable, go straight to resuscitation. That image right there is severe ischemic colitis. Patients that look like that on the inside are at risk for losing a section of their bowel at least. I'll usually make sure those patients are followed up with a CT angiogram if their kidneys are fit, to make sure there's not a major large vessel occlusion or anything like that. The abdominal pain with regards to lower GI bleeding is particularly important, because diverticular bleeds, they don't hurt. There's a big misconception out there in the medical community even that diverticular bleeds are a result of diverticulitis. They are not. They're a result of diverticulosis. So if your patient hurts and you think it's diverticulitis, I don't expect that to be causing the bleed. Diverticulosis, when it's non-inflamed, is at risk for bleeding. Most of those are stopped by the time I get in. I can literally count on 3 fingers the number of diverticular bleeds that I've actually stopped. So luckily they behave most of the time. Resuscitation, ABCs once again. So this is all back to fundamentals. Hematochezia, as we spoke about already with concomitant hemodynamic instability, is likely related to an upper GI source. If you don't know where your patient is bleeding from and there is no indicator of cirrhosis, you can always put in a small caliber nasogastric tube. Dobhoffs are probably not very good because they're so small caliber it's hard to aspirate blood out of the GI tract, but a small caliber nasogastric tube put into the stomach, lavage it with 50 milliliters of tap water, and then suction out that lavage, see what you get back. That's a pretty decent way to assess where your bleed is coming from. Don't forget about simple IV fluids, because oftentimes I'm finding more and more these patients have some degree of chronicity or recurrence to the GI bleeding problems that they have, especially as we get more and more into the use of anticoagulants and antiplatelet medications. And they seem to have unicorn blood way too frequently, and you have to wait for days and days to get the blood from the Red Cross. So don't ever forget about your crystalloids. You don't have to go straight to colloids. So transfuse to a hemoglobin greater than 7 or greater than 8 with massive bleeding, significant comorbid medical illnesses, or if you've got a potential delay in therapeutic intervention, i.e. people bleeding from their colon who are going to need colonoscopy, because those patients have to be prepped. You can't just do a quick EGD. People receiving anticoagulants, the very same is true for upper GI bleeds. Currently, our guidelines do not recommend reversal agents. I have used reversal agents in these patients and abandoned guidelines because of instability, and I didn't think the patient could tolerate any more insults. So it's sort of like trying to put as much weight on the scale in the patient's favor as you possibly can. In that instance, I am a fan of reversal agents, but otherwise I try to stay away from them, and they're not usually necessary. Platelets greater than 50,000, just like the upper GI bleeds. If somebody is bleeding massively, so 3 or more units of blood within an hour, I like to move to more of like a trauma-style transfusion strategy, so go 1 to 1 to 1, unit of packed red blood cells, unit of plasma, unit of platelets, because those patients, as they bleed the red cells, they're losing everything else too that also promotes hemostasis. So endoscopic therapy, for lower GI bleeds or suspected lower GI bleeds where you're seeing blood coming out of the lower GI tract, if you think that the source is upper, as soon as a patient is hemodynamically stable, but within 24 hours, just as in an upper GI bleed. If they're hemodynamically unstable, then, and there's an indicator that you've got a proximal bleeding source, then sometimes you just have to move forward and you've got to take a little bit of a risk with regards to therapy because it may be your only opportunity to save that patient's life. Again, nasogastric water lavage, I kind of told you a little bit about it. There's a little bit more of an explanation there written down as far as how to do that. So if there's bilious return and there's no blood, you can assume that the source is distal because you know you're getting duodenal contents at that point, not just gastric contents. But if you get clear water back, you don't get bile, you can't really assume that the source is distal. Patient may not have anatomy that allows the bile to reflux backwards, and you need to consider a push enteroscopy, which is basically a long EGD. It's just done with a pediatric colonoscope instead. So the way to do colonoscopy when somebody has these bleeds is tap water enemas, a colon purge, then move on to colonoscopy. So if there are high-risk clinical features, as we talked about earlier, this should occur after hemodynamic restoration and within 24 hours. But if there aren't high-risk clinical features after the colon purge, then the next available time slot is totally suitable, and that's mainly because these patients generally stop bleeding on their own, generally not a real severe variety of bleed that comes from the colon. So oftentimes I will not emergently prep these patients, and I will do the colonoscopy 24 or 48 hours later. The way to do a rapid colon purge, if you ever have to do it, 4 to 6 liters of go lightly in 3 to 4 hours. That is asking a lot of a sick person until the effluents clear of blood and stool. You can also use a nasogastric tube. Again, please don't do that if you think the patient may have a variceal bleed or have esophageal varices. But if they can't tolerate the prep, as they often can't, you can instill the go lightly via NG tube. Just make sure that whoever administers the colon prep is not trying to dump 4 liters right into somebody's stomach immediately. You'd be shocked. Unprepped colonoscopy, flex sig is not recommended. These patients have to be prepped. I have people tell me all the time, Doc, I've been having diarrhea for 6 days. There's no way there's anything in there. I guarantee you there's a lot still in there. They've got to be prepped to be able to see. So endoscopic therapy, very much like upper GI bleeds, active bleeding, non-bleeding visible vessels and adherent clots. If lesions have those stigmata, we take care of them endoscopically with the same type of management. Diverticular bleeds, typically we try to clip those, but you can treat them like esophageal varices and you can band ligate them. I find that to be cumbersome and difficult. With angioectasias, which are very, very commonly identified when people bleed with antiplatelets and anticoagulant medications, they're a nuisance. They usually don't bleed very heavily. Argon plasma coagulation is a preferred modality, and usually I'll clip to ligate the vessel on top of that. Post-polypectomy bleeds are things that us gastroenterologists don't like to hear about because it means that we probably didn't close up the defect when we take a big polyp out well enough and we exposed a vessel, and then after it ulcerates, it starts to bleed. We use the same type of therapy for that, heater probe, clips, epinephrine, that sort of thing. So going back to the clinical case, so this is the evolution of what happened in order. So the image number 1 is injecting epinephrine underneath the lesion, and it's just a very small ulcer. It wasn't much bigger than 6-8 millimeters maybe, but that's a pretty good size arterial vessel that's sticking right out of the gastric antrum there. This ulcer just picked a really bad spot to erode into. So after gold probe cautery, that's image number 3, the vessel was cauterized and luckily behaved. Sometimes you'll erode into the wall of the vessel with these devices and really set them off, and they can become bad news. This one behaved, and then I put 3 clips on to ligate the vascular supply. Now, recurrent bleeding is something that we all have to deal with no matter which setting you're in. Particularly within the hospital, recurrent bleeding is something that just happens sometimes, and the high-risk stigmata with the upper GI lesions tend to be the culprits most of the time. So we always recommend repeat endoscopy. It is minimally invasive. You don't have to move on down the road of surgery. Interventional radiology, which has substantially more mortality and morbidity to it. Don't forget that melena continues for about 3 to 5 days after somebody's had an upper GI bleed. I commonly get a call from a nurse in the ICU and they say, hey, Dr. Shepard, so-and-so is still having dark black bowel movements. I always say, what's the heart rate? What's the blood pressure? What's the hemoglobin? And generally, there's stability there. Surgery, it's important to consult surgery when people have high-risk clinical features and they have ongoing bleeding. That may be an indicator that endoscopy it's just not going to be enough. Interventional radiology is wonderful if you have them. I work in about a 200-bed hospital. I have interventional radiology, but none of my interventional radiologists did a lot of embolization after their residency and fellowship training, so I do not have coil embolization available to me. So when my patients rebleed and I cannot get them stopped, I have surgeons that are pretty well versed in oversewing ulcer beds and things like that, and the appropriate types of resection like Bill Roth